we are very honored to have with us this evening a very smart, one of the smartest people I know, gentleman, Mr. Paul Kusserow, who is currently the CEO of Amedisys Home Health, and he's going to tell you a little bit about what that means. But he also was, prior to this, the Chief Strategy Officer for Humana. So when I introduce Paul, I like to say there's not too many people that I know who understand that our healthcare system from start to finish the way that he does. He understands the payer mentality and perspective. He understands the provider perspective. He understands the acute world and the post-acute world. And he's just a really smart kind of Renaissance guy. So without further ado, it's my pleasure to introduce to you Paul Kusserow, our keynote for the evening.
All right, this is exciting. I want to tell you first of all, I'd like to introduce Kate Jones, if you'd stand up. Kate and I are from Amedisys. We're delighted to be here. Kate is our Chief Clinical Officer. If you have any really technical questions or any questions about our business, please go to her versus me. You'll get a much better answer. She's a wealth of knowledge, and we're both excited to be here to start to what I think is going to be interesting and meaningful for us, which is start to change our thinking a little. And in these types of events, that's what you need to do. You need to say, here's how we do our business. Here's how we are successful. Here's some of the things that are coming along in our business. And here's probably where we'd like to encourage some change. So what I'm going to describe for you is a company, the leading home health and hospice company in the country. And and I'll give you some data on it. It's a bit of an eye chart. Amedisys is in 34 states. We are 13,000 employees. We have close to over 10,000 clinicians, so nurses, physical therapists, all doing close to 57,000 visits a day. So we go into 57,000 homes is what we do. And we either go largely for home health, which is we go and we take care of really sick people who are classified as homebound. The other thing we do is in about 20% of our business, we go into homes with people who are dying. And we try to give them and facilitate the last stage of their lives. So the people that we have doing our work for us are incredible people. They're there at the times when people need the most. They provide incredibly good care, and they bring a lot of solace and needed social interaction as well as clinical expertise to the 57,000 people they see every day. That adds up approximately to close to 7.5 to 8 million people we see in general. So I think the one thing that we have learned and what we've gleaned in our company is when you see this many people, you knock on this many doors, you have this many nurses come in and this many people take care of other people, there's some things you'll learn. And so I'm going to tell you a little bit about the healthcare system and where home health is today, where hospice is today, and then I'm going to tell you where I think things need to change and what our vision for change is. And so if any of you all, and also just by way of background, I used to be a venture capitalist. I ran 3 venture funds, and they did pretty well. And a lot of the companies that did well were in healthcare technology. Some of the companies that did well were also in aging technologies. And this is a very good market, so I think you're all in a very good place. You look at the demographics in terms of what's happening, and just in our business, 16,000 people a day are coming on for Medicare, turning 65. The pig and the python, as they say with the baby boom, is it's passing through. We're right at the midpoint of the pig and the python. So people are also living. When Medicare was instituted, the average age, people were living till about 72. Now, if you're a woman, you're living to your mid to high 80s. If you're a man, you're in your mid 80s. So this whole piece of people living 10 to 15 years longer Basically, what it's doing is what they are is when you basically turn 65, you start to show some onset of some sort of chronic illness. The difference was when Medicare picked it up in the 60s, those chronic illnesses and certain things like cancer and heart attacks would most people would die at 72. Now what people are doing is they're living with multiple chronic illnesses for a longer period of time. This is expensive, and it's a whole different type of medicine. Our objective is really simple. We want to keep people in the home where they want to be. As Carissa said, 90% of the people that people talk to say they want to age and die in the home. My question is, what's wrong with the other 10%? I mean, the worst thing you want to do is be in a hospital or an institution. If you see people in these institutions, it's tough. So our ultimate objective as a company is to keep people in the home and to make sure that they can live, as most of us will with chronic illness, to live for those 20 years, live really well, be well taken care of, and eventually die with our families in the home. And that's that's the objective of this company. We have everybody has to have a strategy. I started at McKinsey, so everything has to be in color and strategies, and you try to boil everything down to one slide, and so we spent lots of calories doing this. I think we believe that there's 4 things that are really going to drive most of our business of home care. One, you have to be clinically distinctive, which means the nurses that we have and the techs that we have to be better than other nurses and other techs going into the home or pitching this business to doctors' offices and hospitals, which is what we do. That's where we get our referrals. So we go and we compete for people coming out of hospitals, and we go and compete in doctors' offices for those people that have been declared homebound and do need care in the home. If we aren't, the way that the government, ACA, is moving, and particularly in our industry, it's moving very much towards quality, which we're happy about. It's a good thing. The thing is, what they're doing is they're making very big differentials now in terms of if you're rated as good quality or bad quality. So, and then they're also cutting our reimbursement. So what that basically means is the fluff that was in our system, that the profits that we did have, that we were able to make, is now being pushed out, and now we have to put our quality money in a pool with other people and win on that game. That's the way the government is pushing it. And I think that's not a bad thing, because the people who deliver the best quality will win, and they will get paid the most. So we're betting on that. We're putting our money where our mouth is in terms of that. The other thing is what you'll learn about healthcare, and particularly healthcare services and healthcare delivery, is it's a people business. If we don't have nurses knocking on doors, understanding people, being able to communicate with people, being able to provide care, being able to look at a situation and assess a situation, and then put together the best care plan, we have the wrong people. And so what's very, very important is that we have great people, once again, with great clinical knowledge and great clinical tools that we bring to them. The turnover rate in this business in general is over 30%. As you all know, those of you who run businesses, a 30% turnover rate is really very, very difficult. And remember, this is I think we're up to $3 trillion business now. Home health is 70 billion, I think, at this point. You've got turnover rates, and 85% of home health is people. It's all about people. So our objective here, so as you're thinking, if you want to drive profitability, one of the things you ought to be looking at, and one of the things we're always interested in, is what can you do with our people side of things. Operational efficiency and effectiveness, it's a highly inefficient business. And there's a variety of ways that it's inefficient, particularly the technology that's there. We tried to develop our own technology, it cratered on us. And what we did is we went to an industry-based solution. The industry-based solution now is becoming predominant. The interesting thing was it was a tiny little technology focused very much on this business, largely on the clinical piece, delivering clinical quality on the business. And last year was sold for $600 million on about a $50 million revenue base. So you can do the math. This is a very, very interesting space in healthcare IT, and we're at a very primal level delivering in terms of IT and growth. So you have to grow. If you aren't growing, things aren't going to work very well for you. Traditionally, if you look at where home care is, we're called a post-acute. There's a post-acute business, and we're in the post-acute business is probably around 200 billion. It means the post-acute is what happens to people when they come out of a hospital, and so we're classified as a post-acute business. The idea is somebody in a hospital says, "Okay, Paul's been in for a heart attack. It's time for Paul to go home. Where should Paul go?" And then that's where the rush goes. Should Paul go into a skilled nursing facility? Should Paul go in for rehab? Should Paul go home? Okay? If you look at the continuum of expenses on here in the post-acute world, home is where, first of all, where Paul generally wants to go 90% of the time. And then the other thing is when Paul goes into an institution, there's a lot of issues in some of these post-acute institutions. They aren't great places to stay. These aren't fancy hospitals. And so Paul wants to go home. And then so it's also the cheapest place. The average stay for somebody in our space is about half of what a skilled nursing facility is, which is the second cheapest type form of post-acute institution. The rest so they're up around between 10 and 15,000. Our average episodes are about $5,000. So the key is people want to go home. The government wants you to go home because it's a lot cheaper, and the quality of care is generally better. You don't get infections. It's a place to be. What we think, though, is there's two other elements that are completely untapped in this business. And one is, how do we go straight to doctors and get discharges? About a third of our business actually comes straight from doctors, basically saying, let's get this person some help. We're starting to see some trouble. Let's get this person, let's give them homebound status, and let's figure out how to take great care of that person so they don't end up in the hospital. Let's avoid a crash. The other one is where I think the really big money is, and this is where I think somebody is going to do very, very well, make a lot of money, be transformative, is in what I think there is not only a post-acute business, but a pre-acute business. So that is, how can we take a population of people, and instead of catching them out of the hospital where they've already been beat up, operated on, whatever they've gone through, and then try to keep them from being readmitted to a hospital, how do we take these folks and basically stop them from getting in a hospital, any unnecessary visits to a hospital in the first place? We all know that the statistics on unnecessary hospitalization are probably between 20 and 30%. When you consider the size of the hospital industry, now close to about 700 to 800 billion, that's a big number. So those unnecessary pieces, so who's going to be interested in that? The government should be, but they'll be last to the game. Managed care will be interested in that. People that take risk. Doctors, groups that take risk will be interested in that. So these are the type, and that's a lot of money, and they'll share their money. Currently now, managed care doesn't pay us very well. What we want to do is say, pay us to drop average hospitalizations within a certain population group. So we think that's going to be really a very interesting area, and that's where it'll grow. So that's going to be my theme throughout this. So what I'm going to do is, through the rest of it, I'm going to tell you how the healthcare business works, how it's screwed up from a post-acute perspective, what you're going to need to do pre-acute, what you're going to need to do population health management, what you're going to need to do to keep people in the home. And this is where we'd like to see a lot of innovation. So we would basically like to but we need capabilities. Right now, we're skilled nursing folks. We have skilled nursing folks who basically go into the home after somebody's been in the hospital, and we get paid by the hospital if they aren't readmitted in 30 days. That's how we can make our money. And we get called up again if we have a lower readmission rate than everybody else. That's basically how our business works. But what do we do to start to shift that paradigm? And I think so some of the things we're looking at and that we believe are important are some of the things that exist out there in terms of, and I think this in particular I'm going to focus on mainly data, analytics, and assessments. Because I think these are the key things with a group like you that are important. There are things like drugs, medical equipment that has to be delivered, timely use of drugs, that sort of thing. The key thing, though, is really if you want to influence people and keep people in the home better, what you need to do is you need to assess them. And so that means when Paul comes out of the hospital, or before Paul goes into the hospital, a doctor or nurse should go to Paul's home and say, okay, let's give him a full write-up. See, and there's two things you need to look at when you're giving an assessment for Paul. One is clinically what's wrong with him and what do you need to do for him clinically. And then two, socially and what's called activities of daily living. So what sort of things does Paul need that's going to actually have a clinical influence? So socialization, am I depressed? Chronic disease brings on a lot of depression. Am I eating right? Am I sleeping all right? Am I, what's my world like? How can I improve that world? So there's an element of the social and the clinical which influence each other more than people really think. And so once somebody needs to go in and do that assessment, once you have that, and managed care has done this very, very well. The reason managed care has done it, which is the payers, Humana, where I come from, Aetna, United, they basically go in and send people into the home so they can bill more. The idea is you go into the home and you look at Paul and you say, gee, he looks a lot sicker and he has all these other things and therefore he's much more, his acuity level is higher, so we're going to bill him more. So I think that's one of that's their game. They've mastered it really well. Our piece is, why don't we take some of that knowledge and say, okay, let's take all that information and say, okay, let's keep Paul at home. How do we do that? How do we create and then once we have that data, how do we create a care plan for Paul, specifically and individually, customizable? Because every time I go in the hospital, it's between $10,000 and $15,000. And generally managed care, if you're on a fully capitated basis, it's paid for by managed care. So for every one person that wrongly goes into a hospital, they generally have to have between 8 and 10 people that you have to prevent a hospitalization for. That's the game. Insurance companies lose money when people go to the hospital. And therefore, you have to go to the hospital for the right reasons. This is the old way the world works. On the left-hand side. This is what you're fighting. This is the vortex. This is the gravitational pull of the hospital. This was what was been constructed since the 60s, 70s, and 80s. This is the whole idea, and this is what hospitals are doing right now, is before hospitals would just be independent things. Now what they're doing is you see these other little gray buildings, they're buying up clinics around the hospital. They're buying up specialists, which are the blue guys, around the hospitals. They're buying up primary care doctors, PCPs, around the specialists. And they're creating a web to draw people into the hospitals. That's what they're looking for. They're looking for referrals. If a hospital doctor is owned by the hospital, so there used to be, most doctors used to be independent. Now about 60% of them are owned by hospitals. So what's really important here, and where's the most expensive place in healthcare to go? Right? So what is it driving? What's driving up cost here? That vortex, that suction there. So what we're trying to do, and what's very interesting is I don't know how many of you have heard of ACOs, Accountable Care Organizations. But now the government has basically said, we hate insurance companies, so now we want hospitals to become insurance companies. So basically, the idea is the government saying we need them to change their DNA, while they're sitting in their chair or whatever, which is nuts. So the problem is you've got a fox in the hen house issue, which is now the hospital is being paid to keep people out of itself, whereas before this whole construct was to drive people into it. So this is why I think ACO models are going to be very, very problematic and why none of them thus far have really worked. A couple examples maybe have. Kaiser, Geisinger, some of these other places that have been doing this for a long time. But now how are you going to get them to reject their DNA and push people out to the primary care doctor so that unnecessary hospitalizations, unnecessary surgeries don't occur. So this is the conundrum you have right now. Tons of launches of ACOs, hundreds of ACOs are out there, hospitals taking risk, and now they're trying to figure, they have two businesses that are going on. One is fee-for-service, which is on the left side, which is where they make their money, and then all of a sudden they say, well, we'll make a little more money and do ACOs, and so don't you think those doctors on the outside are really confused? They're extraordinarily confused, and that's why the system is really messing up. This is what we think the model ought to be. And this is why we think home health has the best place in this model. And managed care also does this. The really good managed care people, the people that take risk, know this very well. And our objective is, and see these people in their home, these are people that want to stay in their home. These are chronically ill people who will cost the system hundreds of thousands of dollars. And our objective here is to basically provide home care, working with the docs and the specialists to keep people out of this vortex. And that's the whole objective here. And that's what managed care, the people who in managed care, the payer world, do this well, is they employ home care. Humana does this very well. Cigna with HealthSpring does this extraordinarily well, where they employ doctors and their job, doctors, nurses, home care agencies like ourselves, specialized home care agencies, and their job is to keep people at home. Then their job is to make sure that they employ and coordinate and reward the doctors to keep people at home, not to let them slide into the vortex. If they have to, they go to a clinic that's very specifically oriented towards them, that has all the information on their electronic medical record, that really understands what they're doing. Then if they do have to go into the hospital, this is what's called a narrow network. They go into a very specific hospital. Generally, they have somebody in there called a hospitalist. If you know what a hospitalist is, it's their doctor in the hospital. That hospitalist then fundamentally has to watch that patient and get that patient out of the hospital as quickly as possible. That's the job. And then push that person right back into the home. Now, if you do this right, and you're a managed care person or you're a doctor taking risk, the cost for keeping somebody at home is about 65 cents on the dollar. Those people that take risks, they're people who do it really well. Okay? So if you look at all the healthcare dollars that are out there, those are profit margins that are rarely seen anywhere else. The people that do this really, really well and need the tools to keep people in their homes, and if they can manage somebody in that system for 65 cents on the dollar, get to keep the other 35 cents. Managed care margins, payer margins are between 2 and 3%. Hospital margins are between 1 and 2%. So that's where the magic is. Keep people at home, keep them well, watch them all the time, and don't let them slide into the vortex. So the traditional piece is kind of the bouncy ball thing, where basically people start at the home, they bounce up to the hospital, they go back down into back into the home, and they bounce up again, and eventually they catch an infection, and it gets to be the bouncy ball goes less and less. You know, it's a big one, then it goes less and less and less. They're back. Okay, incredibly expensive. Our belief is let's stop that whole cycle of hospitalization. So let's take some of these things. Let's go and assess people properly. Let's build a care plan. Let's manage and monitor them. This is what Care Innovations does. They do a very good job at this, which is how do we take all that information in the home and how do we bring it in, and then how do we sort through that information? You know, how do we build the algorithms within that information to show abnormalities, and what do those abnormalities mean, and how do you then take care of them? What happens when, for example, when somebody flushes the toilet twice as much? This is the first thing one of these remote monitoring companies found. With men, it was urinary tract infections, which obviously, in most cases, was an emergency visit, and then infections later. Very, very expensive. So it's those sorts of things. When you have sensors, when you know people are opening the refrigerator, getting food, when you know they're lying in their bed and getting 8 hours of sleep, when you know they're moving around the apartment, when you know there's guests that have been in the apartment, when they're getting exercise, these are the types of things you can actually do. But this is tremendous amounts of data. And you have to normalize it, and then you have to show the abnormalities, and then you have to interpret what those abnormalities are. And then what you have to do is you have to decide what to do. Some of it's clinical care, where you hire an expensive nurse at $150 to go in and do a care. The other one, you use private duty people that are $20 an hour. What do you do? And that has to be managed. Because if you put the private duty person in and they can solve the problem for you, and you're taking risk on that dollar, I'd prefer to pay out $20 than $150. I want to use that nurse right, but I want that nurse only when that nurse is needed. And I need that care, I need that model in there to do that. And then what you do is you continually access this. Now, the bottom parts is you also have to coordinate. So there's all of these people that have to be coordinated in to this process. There's your primary care doc, there's your specialist, there's your home care nurse. You know, you go through, there's your physical therapist, there's your family, there's your friends, and there's your community. All these people participate in one way or another in terms of care. How do you coordinate that? Particularly with certain things like med management. If somebody takes their pills, you know, you can solve a lot of problems by just making sure people take their pills on the right time. So how do you do that? How do you coordinate that? Is there a relative that can do this? Is there packaging that can do it? Could you get one of those little things where the light beeps? Do you get an auto caller, an IVR, and somebody says it's time to take your pills? How do you do that? Because I think that's very, very interesting, med management, in terms of how you drive some of these things. So the key is, how do you coordinate this? How do you involve the family? Because most healthcare coordinators, most doctors don't want to involve the family because they don't trust non-clinicians. One of the big revolutions that you're all going to see out there is, if you play in this space where things are really going to move, is clinical work by non-clinical people, particularly families. And how do they do it? The assumption is the knowledge is going to be there, the training is going to be there, and people will be able to do that. So the question is, how do you enable people to be caregivers? And then how do you coordinate that in? And that's where we think the future is going to be. And so the big job here is to stop this, because where you see where the cost is, whenever you go up this continuum, you drive cost. Where you avoid costs is when you keep people in the home. Where you do the planning, you do the coordination, you execute the care, and then you reassess and you do it all over again. And then how do you coordinate all those people, the unskilled, the skilled, the nurses, the specialists? How do you bring all that in? So fundamentally, where we're going to get to is there going to be individual care planning, individual care assessment, individual care coordination. That's where the world's going to go. And when you do that, and you do that well, you knock all the costs out of tremendous costs out of the system. Avoid a lot of unnecessary care, pain, and heartbreak that goes with some of these unnecessary things. So this is my last slide. What we want to do is own the home. Right now, we are skilled people, largely nurses and physical therapists, that go on a skilled basis, that are contracted by hospitals and doctors to do very specific things under traditional Medicare. That area will be commoditized. So eventually, we're going to get commoditized on this deal. Where we need to move is we need to get out of that. We need to, one, expand. So we need to use technology. We need to use all these care coordination tools so that we expand to more acute people. Right now, we have very specific criteria of the types of people we can take care of. So once we have more skilled people with better care plans, we can then start to move and take more acute people and keep them in the home. Right now, one of the things we're working on with Care Innovations is a hospital at the home. We believe there's certain people are admitted into hospitals that could be taken care of in the home. And we believe as technology, monitoring technology, care technology, telemedicine that occurs, we'll be able to take care of sicker and sicker people in the home. So that's why we're delighted to be in this space. I wouldn't want to be any of my competitive folks in the post-acute institutional world, because those areas are contracting, this area is going to be expanding. The other piece is, which we don't play in and other people do, is how do you use relatively unskilled labor to drive down costs, to coordinate the care, to take care of those non-clinical things and do it in an effective and a relatively cheap way. So in terms of, if I were out like you all are in terms of, and trying to find out, you know, if I wanted to make a big splash and make $1 zillion in the home care world, if you look at the capabilities space, I think that's an important place to start. Because if you do this, we'll be talking to you, or at least you should call us. Because this is where we see the action, this is where we see the future going, and these are the people we need to partner with, the people who do that. So we need enhanced monitoring. One, we need real-time feedback, and the feedback has to go into algorithms, and the algorithms have to tell us if there's abnormalities and what those abnormalities mean, and then we have to get the right people there. Telemedicine, we need to actually figure out a way to call on people without actually knocking on the door. So there's a lot of advancement. I don't know if any of you have seen the IPO of Teladoc. It went for over $1 billion. There's some real opportunity, and it's a very small company. The world knows telemedicine is coming, and people are betting on it, and the government needs to reimburse it properly, but that's going to be a very exciting place. Analytics, you've all heard it. There's way too much data out there. We need to know how to interpret the data, and then how to interpret outliers in the data and what that means, and then we have to put that into a care coordination plan, and that needs to be real time. Assessments I've talked about, but assessment is important. If you don't assess somebody, you don't know what their trajectory is going to be. The cool thing is we've seen some companies that are out there that are basically taking existing information and then building trajectories. So they say, you're here right now. If you follow your current path based on all the other people that have gone before you, this is where you're going to end up. And this is how you move. And then so what our job here to do is basically to say, here's how you can bend the curve. Staffing, as I said, 85% of our costs are people. So how do you get the right people with the right staff, the right level of capabilities in the right place, and then how do you employ them? That's going to be very important. And then the care planning and the med management piece. Med management is an easy one, but no one's really cracked the code on that, which is how do you get people to take all their I mean, when you go in, I go on these home care visits quite a bit, and you knock on the door, the first thing the nurse does is says, bring me all your meds. They bring out several shoe boxes, they dump it on the table, and then it takes an hour to sort through the stuff because there's so many pills and most of them are expired, and then you have to figure out who does what when. But if that can be automated, that's a huge, huge value to figure out how to automate it, how to track it, and to figure that all out. So one, I appreciate everybody at this time of night on a Friday night listening to this. I hope you're as excited as I am about some of the potential that can be there with aging in place. We like to call it aging in place, aging in the home. We believe that the industry is just starting. This hopefully will give you some places if you're interested to hunt, to innovate, and because I think if you do start to develop some solutions here, you're going to do well. You're going to do well. You're going to be, because none of these are cracked at this point. So thanks very much. Good luck on your hackathon, and I hope one of you hits a winner, and I hope we do business with you, and you knock on our door, and good success to all of you. Thanks very much.
Paul, before you sit down, we did offer them a little Q&A. So we have a couple of mics here. If you'd like to ask Paul a question, just raise your hand and we'll try to get a mic to you as quickly as possible. But hopefully you're all taking notes because Paul laid out a very good business case and some great numbers to use in your pitches as you formulate your presentations later on. Question?
So your talk is very interesting. And I have a quick question is that you mentioned like big data, a lot of automation or things like that. So, I mean, the biggest factor probably is a lot of costs associated with manual or semi-manual process in health care industry. Could you dig a little bit deeper on how your company startup working on big data and cloud computing for full automation?
Yeah, so let me interpret in terms of, I always have to say your questions back in my language so I can actually get it right, is where do we think automation can be properly employed, and where do we see the impact in home care largely? Is that right? Is that the approach in terms of our business systems and processing?
Yeah, definitely.
Okay.
You can reduce the cost, but you can do better and do more significant. So reduce the
Yeah.
cost, reduce the cost as much as possible.
Yeah. So, as you'll see, so the biggest part of healthcare is healthcare services. And the biggest part of healthcare services is labor. The biggest part of labor is skilled labor. And the biggest problem with the way that we work now in healthcare is it's all episodic. So it's like the same thing as a firehouse. You got a whole bunch of people sitting there waiting for the fire to occur so that when the right fire comes, they've got all the right people and they can go employ it. So from a logistics perspective, there is no models that have really predicted the proper use of labor in terms of, when certain things occur. And then there's been the employment of labor is particularly bad, particularly in our business. So we currently now our average nurse does about 6 visits. What would we do if we could get 7 or 8 visits and we could, like driving? When somebody has a care plan, are they doing the best route optimization? I just talked about how much time it takes a nurse for us to, the nurses, because of the way we have to do documentation, have to write down the medicine of a patient 3 times. So I'm paying that nurse $150 an hour, an episode. And so, I saw some technology, for example, where somebody took their smartphone out, took a picture of the pill, and then they kept doing it, and then it turned into a formulary, and it took a minute or 2 minutes instead of the 25 minutes that it took that person to write it down. Then they also have to type it in at night. So if you look at the workflow and the waste on the workflow of the most expensive piece of this, the inefficiencies are extraordinary. They wouldn't exist in other businesses.
I totally agree with you. So actually, you mentioned workflow, BPA, business process automation. I'm not in healthcare industry, but this is universal to every industry, right? Going from paperwork to paperless, right?
Right.
And try to do better scheduling, resource allocations, all kind of things, By the way, I have a quick follow-up question. Do you believe all of us gonna be alive forever because of singularity? Because of the health technology advancement, all of us gonna live forever?
Oh, do you think we're going to live forever?
Yeah, I'm asking your opinion.
Great. There's actually somebody, my little daughter's here, and there's a myth. There's a myth of, and one of the great demographers of older people literally told about a myth of a guy who basically wishes for eternal life but never gets their health, and I forget which person it was, and then basically he just wasted. He had a miserable life, and he finally asked Zeus to go kill him, which is kind of interesting. The point is, I think what we've seen is as you progress, it just gets miserable. And I think one of the things that we don't see every day, but is what's really important, is mental quality of life. Depression, memory loss is extraordinary after a certain age. And then when you have multiple chronic disease on that, I think it's going to be very tough.
Yeah, of course. At a physical level, our skin or those kind of things, cardiac kind of aging. It looks like there's a new tendency. Our body gonna be integrated with machine. So that's why.
Yeah, they're already putting chips in people, that sort of thing, and I think that, and then there's regeneration of organs and that sort of thing. As I said, I've got a little daughter here. I'm expected, based on actuarial tables, to live into my mid-80s, maybe my mid to late 80s. She's supposedly going to live to 100. So based on the advancements we've got, assuming she doesn't have the habits of her old man, but
Paul, first of all, I want to say thank you. It was an awesome presentation. I really liked it. In terms of the capacities to the ADDs that you mentioned, how would you prioritize those? Which would be the more, I mean, I can see that I think staffing, from what you can tell us, is the most important, but are there other priorities there that you think are pressing, like we need, if we were to develop them, let's say, for instance, they would be really actionable for your industry?
I think if we found somebody good doing home care assessments, and Kate, you can, she's the real smart one here. So if I think if you have somebody doing assessments, that just tees up everything in the complete right way, and then do care planning on top of that. And because currently what there is some of the way that we do assessments, which you can talk to Kate about in some of the breakups, it's called an OASIS. It's a very specific thing. I think you could use that as an assessment tool. And then I think if you use that tool and then put a care plan in place, my guess is there's going to be two results which are going to happen to that. One is because of the new regulations that are going to come out, you're going to get paid a lot more because of these stars quality ratings that are coming out. So economically, it's going to be a really good thing. And then care-wise, you're going to produce phenomenal results. Oh, yeah. 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 Well, ultimately where we're going to do is if we put a care plan together and we implement against that care plan and we do it in an economically viable way, on the post-acute side, after people come out of the hospital, there will be we'll be rewarded by basically readmissions, by reducing readmissions, keeping people in place, and then how we're perceived at quality. So, yes. That's how we're currently awarded. Where I think we will be rewarded in the future is we will go to various plans, initially managed care plans, and we will say, those 10,000 people you've got, you're getting hospital admissions of X. We're going to give you Y, which is much less. You'll save this amount if you do it. We'll split it with you, plus you're going to pay us on a per member per month. That's where the future is going to be, I think. Yeah, and remember, that's huge money. Because remember, so on a per member per month base on your average Medicare patient, you're looking at approximately $12,000 per year for your average Medicare patient. For your sick ones, between $20,000 and $28,000. So you talk about keeping somebody out of the hospital and doing at that amount of money. That's where you can make profits, and that's where you can reemploy those profits into taking better care of people. Yeah. Yeah. I wish I had some sort of vortex sort of theme that I could have worn up here today, but yeah. Yeah, yeah. So there is the people who like it now are those people who are paid. There are doctors in the world, there are plans in the world who are basically given the whole pot of money. But then they're responsible for everything. You have some very good plans around here that do this. Full capitation at Kaiser is a wonderful example. And their job is, and the Kaiser people, and there's a couple examples, Stewart Health Plan in Boston, Kaiser here, they understand a hospital is a cost center. It's not and they want to keep people out as much as they can, unnecessarily.
Okay, so we've got a question here, and then
sorry.
here, there, and there.
My understanding of what you said was that post-acute care is analogous to the Anheuser-Busch Miller of the beer world, where home care is the craft beer industry.
Yes, I like that.
So my question...
I like craft beer too.
My question is, one of the care delivery areas that you didn't mention that I want to hear your opinion on is the PACE, the Program for All-Inclusive Care in the Elderly, and why you left that out or why you think it should be included.
Sure. We don't participate in PACE. Generally PACE, although that's just changed, generally PACE is a not-for-profit, capitated environment for Medicaid or dual-eligible population. And the PACE programs that exist are wonderful, the ones that work well are wonderful examples of all-inclusiveness. The housing piece, the care piece, the activities of daily living piece. I think there's a tremendous amount to learn, particularly in managed Medicaid, which is growing extremely quickly because the reform is now, the states now in terms of reaction of the reform are now saying they want to offset that Medicaid risk and they're going to private Medicaid, and then now there's managed Medicaid. The private people are saying, we'll take all that money the states are going to give us because the states want to offload the risk to us. They're now offloading various pieces of that and farming out the risk. And they're using a lot of PACE type principles for that because PACE is very good at the Medicaid piece. We don't do much Medicaid business, so that's why I didn't bring it up. We do Medicare. Medicaid is much more behaviorally driven. You have to have some behavioral elements to that. It's a very different population in terms of management. Just activities of daily living, social elements, behavioral elements are much more, you have to have much more skill sets there. Kate, is that about right? Okay.
Thank you for a very informative discussion.
Hi.
I said thank you for this informative
Thank you.
discussion. You didn't bring something up that I think would be very important in your area, and that is hospitals are lethal places.
Yeah.
And the more you can keep people out of hospitals in terms of nosocomial infections, the better outcomes would come. But now you did bring up the issue of a 30% turnover, and which is a huge cost, I would estimate. And I'm putting on my occupational health physician hat and having consulted on some home care projects. What are you planning to do for your healthcare workers so you could retain them? I mean, there are two areas probably. One is in terms of what you pay people,
Yes.
and you're talking about, I gather you want to reduce the payments, but increasing the payments for certain groups may lessen the cost. I mean, this has been the experience in several industries. You up the ante, you can reduce the other costs. The other one, what are you going to do about the occupational hazards, which are huge in healthcare and, in home healthcare, and has received very little attention. And again, that goes to the retention issue.
So I can answer the first one. I'm going to have Kate answer the second one. She's better at it, being a nurse and our chief clinical officer. The turnover piece is something that bothers me greatly in our industry, and it bothers me greatly in our company. So we did actually Kate did this work. We brought in a researcher and talked to over 2,000 of our nurses. And what that came back with was very similar to some of the satisfaction goals you get with Gallup. And it's one, do I have a positive work environment? The nurses and the techs wanted that positive work environment in terms of, am I being supported in the mission of what I believe is the right thing to do? Is this environment here for that? The second one is, do I have the tools that I need to do my job? Do I have better tools than somebody else to do my job in the most effective way? And the third thing was on the PACE piece, which is once again talks about the very different types of people that come into caregiving, and that is pay me fairly. I didn't go into this world to get rich. Pay me fairly, so that I don't have to look over my shoulder and have to leave you for something because you're paying me unfairly. So I think what I've seen with people is if you in this space, particularly nurses, if you allow them to do their job, if you enable them to do their job in the best way possible, if you give them better tools than anybody else, your turnover will go way down. I worked at a hospital company, a for-profit hospital company for 7 years before I joined Humana. And so I had the opportunity to manage 40,000 nurses. and that was an interesting experience. In that our turnover rates were about 35%. We brought it down to 17%, largely because we addressed those issues, which was pay you fairly, make sure you have the best tools, better than anybody out there particularly, and then make sure you created a culture of caregiving, and that culture was, was kind of, there was some osmosis in that culture where everybody felt they were there to do the right thing. So those are the levers we believe drive down turnover. Now, the interesting thing you say, considering turnover is 85% of our costs, to replace a nurse, when a nurse leaves us, it's 1.3 times salary. And that's in general, and we're cheap. When you go to a hospital, that's a lot of money. So you add that up, you multiply that times 30%, and that's not something you should be messing around with. Plus the lack of productivity, satisfaction goes down with the other folks. It's a really, really bad process. So I've been in the job 8 months. That's my first goal, is to cut that. And I think if we do a good job there, we'll be a better place to work.
In the pre-acute phase of, shall we call it, the care continuum,
Yes.
there are vast numbers of people retiring from the baby boomers and so on nowadays. And not all of them have a lot to do with their time. Do you have a protocol for tapping into this volunteer labor force, outside of family caregivers, but this volunteer, shall we call them neighbor volunteers or villagers, shall we say? Do you have a protocol for including them in your process of lowering in the aggregate healthcare costs, and then getting your better reimbursements? Any thoughts on that?
Oh, yeah. So I think the best example, and I don't know if you've seen this yet, but I'll encourage you to look it up, is Beacon Hill in Boston, the Beacon Hill community, which is fundamentally a group of... okay, so you know it very well. Okay, yeah, I believe very strongly in that. The question is, and they use a barter system fundamentally for labor, and that's how it works. I think the question is, that we've seen is, how do you attract those folks? How do you then put out a care plan without violating any HIPAA issues, which can be difficult? And then how can you create those communities where there's fundamentally barter points that are generated? I've seen that in senior living communities that have been, since everybody's in the same geography and certain people are at different stages of health, I've seen that go. We like that space a lot. I think it's the far, far future, because I think, once again, and the other company, if you've never seen a company called Senior Link, that is one of the better companies I've seen in Boston with the Medicaid population that fundamentally uses unskilled family members and reimburses them with real money. Yeah. So I think that's interesting. The way I look at it is, how can you create a coordinated care plan with those resources and include those resources that are available to you? And then how do you drive those resources in? And then who's the care coordinator behind that that's driving it? And I think what we've seen is, when you have unskilled kind of people way outside the care plan, that one person's in the middle, you have to have very specific care coordinator drivers, because people then don't know how to interact. I think it's a lovely idea. I agree. I totally agree. And I think if there was some tool to get people to volunteer, to coordinate that, to build that and integrate that into the plans, and have some sort of volunteerism there, that's great. But I do think they need supervision. And I think people like us I can see my lawyers right now just freaking out on this one. Hospice, exactly. Hospice is a great example, Kate. That's good. Yeah, that's required. So maybe there's a lead in hospice which takes a much more holistic approach, integrating the family, integrating, counselors, social workers, as well as the community. So that might be the place to start. And we do that, so that's a good idea. I mean, if we could expand the hospice knowledge into, okay. Yeah. Yeah. And there's been some startup healthcare plans that have fundamentally tried to use that as a barter system. So you get your premiums reduced if you go help somebody else lower their healthcare costs. And then there are current plans now which are fundamentally bet on yourself healthcare plans, which is generally for the very healthy. The people say, I'm going to run every day and eat well and not do anything bad, and I'm going to go into these, and I'm going to bet on myself, therefore get really low premiums. And so those types of plans are starting to emerge.
I'm just wondering, I just want to add to his comment, his ideas. We are sitting too close, I think. We are thinking like, so the body being the physical body being the only resource for a human being. We have 7 billion people here, and we spend about 12 years in schools. And if anything happens in this room, other than the doctors and the healthcare providers, no one can help until the emergency arrives to someone.
Right.
Right? I'm just wondering why this is a case. We are educated several things, but not the basic, the $20 skill set that you are looking for. Why are we not taught at the school level that basic skills that definitely not going to be like doctor level or very complicated one. That is the basic skill that every human being should be taught in the beginning in their school ages itself.
Well, so one you're preaching to the converted, so I totally agree with you. The other thing is that I think is important about what you're saying is we have seen, and I saw this in my managed care payer days, is if you're smart about your disease, if you learn your disease, if you learn what you've got, you generally have better outcomes. And so what we tried to do is we tried to incentivize people to learn their disease or to learn before they went into surgery what would happen in the surgery and learn what recovery would be like, because then they could visualize it. They could have fundamentally create a care plan in their head, and then they would have much better outcomes. People, particularly in
that's one thing. But what I'm talking about is how the healthcare people. Is it possible to make it as a compulsory course? I mean, the education became mandatory, right, for 12 grades, up to 12 grades. So can we also make this course as a mandatory in the schools?
Yeah, so one, I love your idea. Two, it's currently doesn't exist currently, right? So I think the idea is if we ever want to, health is important. I think we're in a health era. So I think that's, instead of taking shop and home ec, I think it's probably better maybe as you go and you learn about healthcare. Because I think if people are smart about it and people understand what diabetics are and people understand, how to think about the right things in terms of healthy living, I think there's going to be, I think the outcomes and the awareness levels will be that much better. But currently, I don't see it. I mean, it's sad.
So, and for the volunteering, the hospitals or insurance companies, they are spending billions of dollars on taking care of the medicines and the other things on the chronic diseases. So could they spend money on training the people who are all interested and give them certified, like the private care people or even myself, people in the family, people, whoever interested, and they can go to the nearest hospitals and get trained from the volunteers who are retired and get certified, qualified, and be ready as and when they are required, they can go support neighborhood. Even it could be in this room or it could be for the neighbors.
Before you answer that, in the essence of time, it's now 5 after 8. I'm going to say you take the
I'll
last
take
two
the last
questions
one.
and you can answer all 3 of them in one big ending.
Okay,
So
one big,
we've got
one big.
Robert here, and then the gentleman here will be the least question, and then Paul will
Thank you
answer.
so much.
Okay. In terms of, look up this company's senior link. It's fundamentally what it does. We all remember when we all used to play cowboys. We all used to get a deputy's badge. That's the company that gives the relatives a deputy's badge for Medicaid people. They basically say to, I'm grandma, and I live at home, and I've got, and this is Medicaid, so this is generally lower income, poor population. I've got Sonny Boy here, who's my grandson, who is in a nowhere job, let's say, and I'm creating stereotypes here, my apologies for that. But what you then do is you say, instead of working at a menial job, we're going to teach you how to be a caregiver. We're going to pay you $17,000, $18,000 a year, which is, it's good there, to learn how to be a caregiver. And you employ that non-clinical person who has a vested interest in making this person well, either a neighbor, a relative, something like that. And the outcomes those people have seen have been phenomenal. But that's what you're talking about, is because there's not enough clinical workers, the non-clinical workers are now being asked to step in on this. It's tricky, but it's certainly happening.
I would say to add on to that, Paul, the difference in Massachusetts, what he's talking about, and California. In California, they just pay them, but they don't train them, they don't educate them. Whereas in Massachusetts,
Right.
it's a comprehensive program, so you're both incentivizing them and rewarding them for it, but you're also providing them the training to do a better job.
Couple questions. The first is, as you try to look to create a village mentality to intervene pre-acute, HIPAA seems to be a huge obstacle
Yeah.
for anybody getting involved.
Yeah.
So the first question is, how do you see breaking down that barrier? Because the medical field can't talk to the volunteer field for that reason. Even so, I think the patients really, it's not their issue anymore. And I guess the second question, which is a little bit unrelated, has to do with Alzheimer's, which once there's diminished mental capacity, it seems to put people who don't need very much medical care into a whole different realm. And that problem's not going away.
No, it's getting worse.
And so how do you see this system working? Partially HIP is an issue, but through this rising Alzheimer's epidemic.
So the Alzheimer's question, we've seen a lot of technology, largely initially seen in something called wander management. And I'm not being funny or flippant, but when in certain places where they have electronic things where your dog, if your dog has a collar and crosses over, it really hurts your dog, therefore your dog stays in your yard. This is a bracelet which basically indicates where that person has gone. It translates where that person has gone, and when that person leaves a certain parameter, they do that, they leave. So there's keeping people in place with wander management technology that has been out there fairly regularly. That's where it started. But the ultimate, that's not the right answer, because the right answer is how do you make their lives meaningful and all that. And I think the question is, what people are trying to do is say, how can we keep these folks at home to a reasonable level? And then after that, it's fundamentally institutionalization. And your first question I just spaced. Oh, HIPAA. Look at patients like me. Have you ever seen patients like me? It's out of Cambridge, Massachusetts. I had a daughter that worked there this summer. They are a social network for people, with common diseases. So they're a community of people with the same disease. They get together and they exchange information, generally on therapeutics. So what sort of regimes are you doing? Very, very active. They instill that, or they infuse it with information that can help these people. And as a community, they get smarter. And therefore, it's a very interesting idea because the community intelligence gets better and better, and they share, and they're also very good at support because these are tough diseases, ALS, some of these other things, these are tough. So, and they've really been able to advance people to create a lot of infrastructure there. So I think that has occurred, and I don't know specifically what they've done about HIPAA issues, but they certainly have addressed them and gotten around them. And I think it's largely because these communities are so strong, people are willing to put aside their HIPAA issues and fundamentally sign that over. Assessments are generally done for us to, in our business, and once Kate, the technicalities Kate would understand better than I, in our business, you have to do an assessment to get paid for a course of care. So the question is, the managed care companies have been particularly good at this because they take what's called a RAF score, which is how much you get paid per that person, depending how sick they are. And generally, when they go in and do this, they raise their RAF scores tremendously. So the idea is they get paid much more because they find a lot more. In general, when you go in and do these assessments, people tend to be sicker than you think they are, at least according to them, which is probably right. In the home care business, what we have to do is we have to do an OASIS. We have to do this assessment so that we can produce the right care plan. So we have to do that anyway. So we look for potential for falls. We look for other things that potentially allow us also to get, to make sure proper care is delivered and to make sure that we have the right people at the right place, utilizing them in the right way. So in home care, we have to do that anyway. Yeah. The interesting thing for us is if this is episodic, we just do it once. Look at all that data we lost, that we could potentially be a benefit to other people, not from a commercial perspective, but from a continuum of care perspective. So the question is, we got to take this learning and we got to drive it into a better relationship with that member. And then, and we have that information. We can translate for them. We can take them to other places. We can advocate for them. The question is, it's very episodic with us, and we have to get out of that. The one thing I think that's really important about healthcare is it's continuum data. If the data is episodic, it never does any good. But if it's a continuum of data and a continuum of care, you really can drive some interesting results.
Please join me in thanking Paul for the very interesting
Thank you,
keynote.
everybody.